Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, an ECG management consultants company. We are a national healthcare consulting firm that is redefining healthcare together with our clients. In this program, we will explore the big trends in healthcare and have real conversations about how provider organizations can meet today's challenges, strengthen performance, and transform care delivery. Value-Based Care Insights is hosted by Daniel Marino, principal at ECG. For additional insights, visit ecgmc.com. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. In today's episode, it's kind of a follow-up to an episode that we had probably late summer, early fall, where we dove into the CMS team model, transforming episode accountable model of care. And at that time, we had talked about the elements that went into team. We talked about the mandated organizations and what the responsibilities are and so forth. Well, the team model launched officially January 1st. And again, it's a 5-year program that would include at the end of 2030. So part of what we wanted to work through are, again, what are some of the key things that we're seeing right now through some of the hospitals and the health systems and the organizations that have been participating in it. And especially as we're working through these first couple of months, what are some of the drivers of success? So, it's important as we think about it to continue to focus on how the information that we get and the understanding related to CMS and really what their goals are. Well, I'm really excited today to have one of my colleagues, Heather Flynn, who is a healthcare strategist. She is an industry expert in understanding policy and sort of the CMS regulations and the drivers, and she has a lot of experience helping organizations put these types of programs in place and really help to drive some of the success. Heather, welcome to the program.
Hi, Dan. Great to be here. Thanks for having me.
So, Heather, let's kind of start at the beginning. Let's talk a little bit for some of our listeners who may not be that familiar with TEAM. What are the key elements that are included in that? And probably more important, what are the goals of CMS as they've started to launch TEAM?
Yeah, when you look at CMS's goals around value-based care, they've always been trying to increase coordination, decrease spend, help redesign care processes, and incentivizing more efficiency in care. So when you try and think about what conditions they're going to focus on, TEAM is not that much of a surprise. It is kind of a next generation of BPCI Advanced and CGR that we've seen in the past, which continue to target a few things. So CMS is going to look for areas of high spending in Medicare. They're going to look for areas of high volume, but also high variation. And I think that's what a lot of people forget is what all of this is really aiming towards is to increase standardization. CMS wants predictability around cost, so they're going to target conditions where there's a lot of post-acute care spend that could go one way or the other, and episodes could look really different. They want to push the system to align on a care pathway that kind of makes things a little bit more predictable.
So one of the things I find interesting is the 5 high-cost surgical procedures, or the 5 procedures that they have, right? So it's the lower extremity joint replacement, the surgical hip femur fracture, spinal fusion, CABG, coronary artery bypass graft, and then major bowel procedures. In your opinion, why did they select these procedures? Is it because these are the highest volume ones? Has this created the most cost variation? What have you seen, or what are your thoughts behind why CMS maybe selected these?
Yeah, I think it's a few things. I think it does check the boxes of high spend, high variation, high volume, but also with cases like this, there's a clear quote unquote trigger or start to an episode. It's a very definitive, the procedure is where the episode begins, where when you try and target more like chronic conditions, for example, or some other things, it gets a little bit harder to define. So these are really easy episodes to where does it start and where does it end? But it's also where CMS sees a lot of fragmentation of care. So these are procedures where there are a lot of providers involved. There's often multiple care settings involved. So it's an opportunity, again, for them to increase that coordination, increase that efficiency, and try and have the system be more coordinated in how they handle these high
Hmm.
volume, really often cases that hospitals are seeing.
So the 741 hospitals that were mandated under the program here,
Mm-hmm.
um, were these the ones that maybe had the highest variation, or how are these hospitals selected?
Yeah, CMS uses a pretty um, randomized, as they say, sample of statistical areas in the country. So they try not to select specific hospitals based on their past experience.
Right, their performance.
Correct. But what I will say is the downside to that, that a lot of people will push back on the models about, is within a statistical area, you're going to have really large health systems, but you're also going to have really small community systems, which are going to experience this model very differently.
Hmm.
They're going to
Good
have a
point.
lot of different capabilities, but they're essentially going to be evaluated similarly and based on each other when you consider regional settings of benchmark prices, for example.
Yeah. And, when we've looked at it, it's, for some large health systems, one of my clients is 13 hospitals. Only one of the hospitals is included as the mandatory hospital. So I think to your point, it's, maybe the algorithm or the statistical analysis they did to select these, possibly wanting to just get a good, I don't know, structured representation of the different hospitals in the different areas that they can begin to test and drive some of the success.
Yeah, we see that a lot across models, and it's never a perfect science, and that's one of the things that CMS has struggled a lot with, is they're trying to be simple and straightforward in their methodology, such as a random sampling of core statistical areas. But by doing so, then they can't account for nuances like what you're mentioning of what if you have one hospital that's included in an area, but
Mhm.
then in a neighboring county, that county is not included. Then you're kind of 1 foot in, 1 foot out, and that makes it
Right.
harder for that system to then manage. But then expecting CMS to account for those complexities then makes the model more complex, harder to understand, harder to administer. So it's a little bit of a balancing act.
So I know we're only 2 months into this, maybe 3 months into this. What are you hearing? How are the hospitals, those that are mandated and working through this, how are they doing? What are they struggling with? What are some of the things that you're hearing?
Yeah, I don't think there's nothing revolutionary here. I think it's the same challenges that we've seen with all models,
Hmm.
especially mandatory models. It's the operational burden, the upfront investment that's required to manage these patients and manage them well and succeed in the model. So, how do you track these episodes? How do you get real time data? That's really
Yeah.
tough, to know what's happening on the episode in real time and be able to intervene if you need to, because you can't wait for the CMS data, right? By the time CMS gives you data on your episodes, it's too late.
Yeah.
So not only tracking the patient's data wise, but also making sure you're capturing everything from a coding perspective.
Yeah.
There are some adjustments for high acuity and more complex patients, but only if the hospital are capturing those aspects around the patient. So I think the data and the coding, the documentation is one piece. And then you have this other piece of care management. How do they manage care outside of their walls? How do they coordinate with post-acute care? But also, how do they start this up front and kind of do the pre-op evaluation that helps them set the stage, and have a good plan for this patient kind of before the episode even begins?
Yeah, I want to dive into care management, but before we do that, I want to go back to what you had mentioned on coding and documentation, because the data is so critical here. And what we see now, we've helped numerous organizations, numerous physicians kind of improve, for instance, their HCC coding, and still with many organizations across the country, the capture recapture rate of HCCs is only about 65-70%. And it puts organizations in a really difficult position. And I can't help but think that those that are included in team, if you're not, if your coding isn't up to, a reasonable level, certainly with the HCC coding of that 90-95% threshold, and the documentation isn't accurate, that really has to be 8 ball. And I think you can start to extract your own billing data, maybe the pre-adjudicated claims in order to evaluate it. But if it's not good data, you're not going to be able to really act on it, and you're going to miss that opportunity. Is that what you're seeing with a lot of the hospitals is right now? Is they're starting to move forward with really understanding the population related to team?
Yeah, I mean, data is always a consistent challenge. Not only having data real time that you pull, but also understanding the CMS data that comes out later. I think, again, especially this goes back to those smaller hospitals that might not have these robust data systems in place. And all of a sudden, this team model is kind of placed in their lap. And they have to figure out how to track these patients. And especially then, not only with data, but then when you think about when the volume comes into play, it's kind of a double whammy, right? Of if you don't have the data, you don't have the coding, but then also maybe you have a small volume of patients, you lose that law of averages that those big health systems have on their side. And it becomes a tricky formula to make it work if you don't have the ability to track patients, to look at the data, but also the volume to account for if one or two patients kind of become a high spend episode.
Yeah, kind of change the curve, if you will. If you're just tuning in, I'm Daniel Marino, and you're listening to Value-Based Care Insights. I am today talking with Heather Flynn. Heather is an industry policy expert, and we're talking about the team model and really kind of doing a quick review on the last couple of months as we begin to move forward with kind of really evaluating some of the successes of team. So, Heather, I want to build on one other thing that you mentioned related to the data. Risk stratification of these populations, I think, has to be critically important, right? Because without understanding the risk factors that go into candidates for these procedures, I think it puts these organizations at a disadvantage related to maybe the pre-surgical evaluation that they need to do, but probably more importantly, planning for the post-surgical recovery. And oftentimes readmission rates, whether it's through the ED or complications post-surgery, aren't as a result of what happens in the OR. It's as a result of other things that are complications to the surgery. So talk a little bit about some of the challenges maybe that organizations have as they're starting to really work through that risk stratification and what they need to do in order to really think about proactively managing these populations.
Yeah, I think you make a good point that a lot of the spend, and especially the variability in spend, happens post-discharge. So I think a lot of folks focus on the post-discharge, but to your point, planning for post-discharge is going to happen pre-op. So I think to your point, it's not only risk stratification in terms of identifying chronic conditions that might come into play, how can you help manage those, but also help promote other healthy behaviors. A lot of times we hear that called prehab, if you will.
Right.
But also setting the patient expectations can be a big factor too. So not only coding that patient, but talking to the patient and saying, where are you going post-discharge? What will that look like? If you're going home, who will care for you post-discharge? You don't want this to be a surprise that after the procedure, then you're starting to have these discussions about what is post-op going to look like and where's the best place for that patient to go. So based on that risk stratification, you could either have the conversation about going home and what that home care would look like, or you could start talking about post-acute care, outlining those options, and hopefully having that option selected, again, pre-op. Because the other challenge you see hospitals running into is space with post-acute care providers. You don't want to wait until after the procedure to find out that all of your preferred providers have no space for your patient, and then that results in a longer length of stay. And again, that goes to the quality scores and impacts that
Well, it fits right into what you had started talking about before, was the whole care management piece of it, right? Because then you become a little bit more prospective on the care that you need to manage with the patient post recovery, and then where the patient, the best opportunity for the patient to recover, whether it's at the home or a post-acute provider. Um, Talk a little bit about the importance of partners, though, to this, because, again, although the hospital, I think, is held primarily accountable to costs and the activities around the episode, the post-acute providers, the SNFs, the rehab facilities, I think have to be critically important to this, because, a large length of stay with a post-acute provider would certainly totally disrupt the whole cost model related to that episode.
Yeah, exactly. As I said at the beginning, we're trying to decrease variation here. So you want to standardize your care pathways where you can. So that means working with your post-acute care network to align on care pathways by condition. How are you going to coordinate care? What does data sharing look like? Is that feasible? So you both can be on the same page. That would also enable the hospital to track that patient real time, because once the patient leaves the hospital, you still need to understand where are they in their post-acute care journey. The hospital's on the hook for 30 days post-discharge. So that hospital needs to continue following up and have a relationship with their partners to be able to understand, is this patient tracking as we would expect? Or do we maybe need to reevaluate? And if you don't have those open lines of communication and or the actual data sharing with your post-acute care providers, that becomes a lot more challenging. It becomes a lot more of a manual process of calling the providers and waiting for a call back. And that's when things can easily fall through the cracks.
Yeah, that coordination with the post-acute providers and the partners, I think, is critically important, because without that, like you said, then things end up breaking down. Oftentimes, when we work with organizations, the transitions of care really is the difference between success and failure related to achieving some of these readmission goals and so forth. And I think you need to have the partner there that really is aligned around the care plans and the care models. Um, Talk a little bit about quality. How is quality fitting into this? I know it can't just all be about cost. It can't be all about utilization management. Certainly efficiency and reducing clinical variation is really important, but quality, obviously the quality of care and making sure that the model and what we put in place has to drive the highest level of quality that we can provide. Where does that fit in on the indicators and the evaluation of team?
Yeah, I think the quality score is overlooked, in my opinion, far too often. I think a lot of a lot of folks look at the quality score as, a little adjustment that can, give you a little bit more of a bonus or perhaps take a little bit away. But especially in team, the quality score is going to be much more impactful than that. And not surprisingly, I think CMS did this on purpose. They are trying to drive quality of care and ensure that while we increase efficiency, we're not compromising quality. We're not increasing readmission rates or hospital acquired conditions and things like that. So when you think about the composite quality score that a hospital is going to be assigned in team, it's really powerful. It can sway the reconciliation amount by positive or negative 10% in some cases.
Wow. Yeah, that's quite a bit.
When you think about a hospital who might have otherwise had really efficient spending, they might be set to receive a reconciliation bonus or positive payment from CMS. But if they have a negative quality score, or they receive like a negative 10% adjustment, for example, on quality, that bonus could now become a repayment amount.
Yeah.
So you really can't ignore the quality score. And I think that's kind of what comes from the preparation of, we're not only looking right now at what do your readmissions look like, where are your care pathways, who are your referral partners, but also what is your length of stay, what kind of outcomes are you having? If we look at by condition, what the quality scores are that are included, how are you performing on those currently? And what would we expect that to impact your team participation and
Yeah.
success?
Well, and that's such a, that's a good point. And sometimes, although, again, quality should always be at the forefront, and I think most of the time it is, it's very easy to get involved in the process of managing the care instead of thinking about that with how it's going to impact quality and are we really driving to some of these success indicators. So, we've covered quite a bit. We talked about the data, we talked about care management, we talked about, quality and documentation and coding and so forth. When you think about, there's a lot there, right? So when you think about the key things that are really important for these health systems, the 740 or so that have been mandated, are there two or three recommendations or a couple of things that you would really recommend that the hospitals focus on as they think about moving this forward, really impacting some of their outcomes and their overall performance?
Absolutely. And I think some of them we've already talked about, but if we're going to recap, I think where I always recommend health systems begin is know your baseline, know your degree of current risk, or as I call it, your current state assessment. So to the extent you can, with the data that you have, understand by condition your volume, your average spend, your variation by surgeon. You can look at this as law of averages, but this differs by surgeon sometimes. Where are your discharge destinations? How are you capturing the data? Are you capturing those comorbidities, or are they often getting missed? And then, as I just mentioned, how would you perform on the quality score today? So let's start by figuring out where we are right now before we try and change anything. That gives us a sense for what are the highest priority items and the most impactful items that we can change to be more successful in team. I think a lot of times hospitals can get bogged down in the details and focus on the small tweaks here and the little upgrades there, but let's figure out what's going to be the most impactful changes that are going to result in the biggest improvement in our performance and team. So
Yeah, that's a great point.
That would be one. And I would say second would be, again, the data piece. We've talked about this quite a few times, but how are you going to build real-time data visibility? How are you going to track those patients during the episode? But then take it a step further. And I think part two of this is if you are able to intervene, then how are you going to intervene? So if an episode starts to go off plan, what is your plan B? How are you going to intervene? What tactics are you going to use? And then lastly, we also talked about it, but I can't reiterate enough the importance of your post-acute care network, referral partners, care coordination processes, data sharing to the extent possible. But I think one nuance to this as well that we haven't touched on yet is your post-acute care network and these care pathways only work if the hospital physicians and surgeons are participating and bought in and they agree with this. You need their buy-in and their participation to make this whole thing work.
Well, and as you were going through this, I mean, that was going to be one of my questions is where do the surgeons fit in, right? I mean, as a best practice, should the hospital think about putting together some type of an integrated governance model that would include hospital and the hospital operators with the surgeons who are driving this, as well as then incorporating maybe some of the post-acute partners?
Yeah, I think when hospitals take more of a participatory approach and everyone is at the table from the start to say, with the surgeons and our post-acute care partners, but also our care management team and our IT folks, what does the episode look like? And what should this care pathway look like? And how do we all come to the table aligned? I think it's challenging to, behind the scenes, develop a care pathway and try to hand it down. That usually is not as successful.
Well, it needs to be physician-led. There's no doubt about that.
Yes.
The physician is really the one that's driving this. Well, Heather, this has been great. Again, it's always fascinating to understand or to kind of dive into a little bit of the drivers and the motives around CMS and doing putting forth some of these programs. And then, again, the hospitals and the health systems are at different places in terms of their capabilities and their infrastructure. So being able to sort of raise those capabilities up to align with what CMS's goals are, I think always remains the challenge. I appreciate you sharing your insight on this. If any of our listeners are interested in contacting you, maybe learning a little bit more about some of the policies or maybe just some of your experience that you have in working with some of these hospitals, can you share your information?
Yeah, of course. So on LinkedIn, I'm under Heather Flynn Kearney. You can reach me there, or happy to share my email, which is going to be HMKearney, that's KEARNEY at ecgmc.com. Happy to chat more or share some more insights.
Great. Well, thanks again, Heather, for coming on. Really appreciate the conversation and really appreciate your insights. This was fantastic.
Thanks, Dan. It's been great.
And for our listeners, if you're interested in learning a little bit more about this topic, Heather and I are doing a presentation, a webinar through Healthcare Financial Management Association, HFMA. The webinar is going to be April 29th at 1 p.m. Eastern Time, so look for more information on that. If you're interested in learning a little bit more about this topic or other topics, please feel free to visit luminahp.com or ecgmc.com as well. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Thank you for being with us today. If you're navigating the shift to value-based care or looking to enhance the performance of your organization, we're here to help you move forward with insight and impact. Visit ecgmc.com to connect with Dan Marino and explore our advisory services. While you're there, check out our latest insights and thought leadership, follow us on LinkedIn, and join the conversation using hashtag VBC Insights. We're Lumina Health Partners, an ECG company. Until our next VBC Insight, keep leading the change.